Supplemental Anatomy Review, Week 1, Part 5, Foot and Ankle. Really quick, you guys, before we get started, just to recap from the previous video, I found this good image of the plantar aponeurosis. As the great toe goes into dorsiflexion, you can see how the aponeurosis is stretched and how this increases the arch and puts the foot into a more rigid structure. And so hopefully this will make the windlass mechanism a little bit clearer for you. Alright, we're going to look at the joints and ligaments together. I'm going to review the joint and the planes of motion it travels in, and then we'll talk about the ligaments to help support that specific joint. We'll begin with the most proximal of the foot and ankle and then work our way down. So we're going to start with the talocrural joint, which is also typically known as the ankle joint. It's comprised of the tibia, the fibula, and the talus, of course. And with the talus, it's primarily going to be articulating on the trochlea, remember that rounded part on the top, and then the sides of the talus where the malleoli are in contact with it. Again, the talocrural joint is a mortise joint that has a natural stability because the high amount of congruency and configuration of this joint, they fit very nicely within each other. According to the Newman book on page 580, it states that 90 to 95% of the compressive forces pass through the talus and tibia, and the remaining 5 to 10% pass through the lateral region of the talus and the fibula. So we have majority of our weight, again, directed towards this medial portion, coming right down over the medial longitudinal arch. So that's where our center of mass is directed towards. Also, the articulations between the tib, fib, and talus have about a 3 centimeter articular cartilage that's able to compress during loading times to help protect the bone from high levels of impact and stress. Alright, so let's talk about the axis that the talocrural joint is in. So, common to popular belief, if you were to put a pin right here through your malleoli, your ankle joint just doesn't hinge perfectly. Alright, it's not a straight across joint. It is oriented in an oblique axis. So it's in an oblique axis in two different planes. So if you look at the frontal plane, you can see that the ankle joint axis is not parallel to the floor or tibial plafond. So what do I mean by that? So this is our tibial plafond, and pretty much it's going to be about level if you were to draw like a line from both sides of the distal end of the tibia. It's going to be about level. Let's see if I can do that real quick. It's going to be pretty much level or parallel to the floor. Alright. However, our talocrural joint does not perfectly hinge along this line, right? So what our talocrural joint does is it hinges approximately 10 degrees from this. So if we go through, remember it's through the tips of both of our malleoli is going to be where our hinges. So this is not going to be a straight line at all. Oh my gosh, that's terrible. Alright, but you get what I just want to keep doing that because that looks bad. Anyway, okay, so it actually is going to be roughly 10 degrees off of the tibial plafond or the surface of the ground. So we have about 10 degrees that we're playing with here in the frontal plane. Just a side note, I believe that there is a typo in the second edition of the Lusardi book. It says that the talocrural joint is angled 10 degrees in the transverse plane, but just by the wording of the paragraph, I believe that they meant to say from the frontal plane. The Newman Kinesiology book, the Atlas of Orthoses and Assistive Devices, and the More Clinical Anatomy book all back me up on this. So I believe that the Lusardi book might have a typo in it. I'm looking again at the second edition on page 180. Not quite sure how the third edition is going to play out with that. Alright, but just for your guys' sake, from the frontal plane, the ankle joint axis is 10 degrees, obliquely oriented 10 degrees. Alright. Okay, and then when we look at the talocrural joint from an aerial view or from the dorsum, it is oriented again in another plane. So when we compare it to the knee joint axis, it is going to be externally rotated 20 to 30 degrees. All right. So here's going to be our knee joint. There's our patella and our femoral condyles. Don't look at this part. That's our hip. But All right, so this is our knee joint, and it is going to be straight, I guess you can say. And then theoretically, if I get, let's go with green. So if I copy this line right here, and if I were to lay these images on top of each other, I have this green line here, the axis of the foot is going to be 20 to 30 degrees externally rotated, okay, from where our knee joint axis runs. So again, this is our knee joint axis. Let me draw a perpendicular line to that a little better, okay? And what they're saying is that this angle right in here is going to be 20 to 30 degrees, okay? So 20, this is going to be really bad. 20 to 30. Oh my gosh, let's just stop. All right, 20 to 30 degrees externally rotated from our knee joint axis, okay? All right, so the movements also allowed by the ankle joint are going to be dorsiflexion and plantar flexion, all right? And that is going to be movement in what plane? The sagittal plane. Yes, sagittal plane. So according to the American Academy of Orthopedic Surgeons, typical passive range of motion is going to be 20 degrees of dorsiflexion, and this image shows 45 degrees, but again, the AAOS says that it is actually 50 degrees. So, but, I mean, there's variance between people. We're not all exactly the same. But general numbers to know are going to be 20 degrees of dorsiflexion and then 50 degrees for your plantar flexion range. All right. When the foot is in neutral, it is considered to be at 0 degrees. Some people want to say get the foot to 90, which I guess since it's making almost a right angle with your tibia and the foot, you could consider that. But neutral is considered to be 0 degrees for this. Oops, sorry. Okay. So, just as a little recap, if we have 10 degrees in the frontal plane and 20 and 30 degrees in the transverse plane for our angulation of this joint, and then we have movement in the sagittal plane with dorsiflexion and plantar flexion, we're crossing all three planes when we dorsi and plantar flex at our talocrural joint. So, therefore, the talocrural joint is considered to be a triplanar joint. Okay. All right, let's take a quick look at the ligaments that are supporting this joint. We'll go right here. Okay, so anteriorly and posteriorly we are supported, as well as medial and laterally. So in this image, look at the anterior and posterior portions. These are really helping the tibia and fibula to stay closer to each other, but again, that helps to bring it helps to form a tighter lock with that talus. So it's not exactly crossing the joint like these other ligaments are doing, but they definitely help bring that joint into a more compact position by bringing the tib and fib closer. So we have the anterior tib-fib ligament and then the posterior tib-fib ligament that help keep that joint together. All right, so now let's look at our medial and lateral. So the joint is firmly held together medially and laterally by the medial ligaments and the lateral ligaments. Very appropriately named. Anyway, so, all right, let's look at the lateral ligaments. There is the posterior talofibular. So all of these ligaments are going to tell you pretty much where they run to and from. So posterior talofibular ligament, calcaneofibular ligament, and then anterior talofibular ligament. So on the lateral side, we have an anterior and we have a posterior talofib, and then we're going to have a calcaneal fib. Okay, and then let's move over to the medial aspect of the foot. This is the medial ligament, also known as the deltoid ligament. So we're going to have the tibiotalar posteriorly, tibiotalar anteriorly, tibiocalcaneal, and tibionavicular. All right. So on the other side, we have the exact same named joints, except or exact same name ligaments, just with different endings. I don't know if that makes sense, but they pretty much have the same name. You have 4 on the medial side and 3 on the lateral side. Okay. The next joint is the subtalar joint, which is the articulation between the talus right here and the calcaneus. I know you guys have seen this image before in the intro to P&O course. But the subtalar joint, again, is located at an oblique angle as well. This oblique angle varies quite a bit from person to person, so I'm not going to go into as much detail as I did with the talocrural joint, but you can read more about it in the Newman book on page 586. But it's pretty much 42 degrees, 40 to 42 from the floor, and then 16 from the second toe out, or from your line of progression. I think this value is from the line of progression. I'll double check that. Anyway, go and look in your Newman book and read a little bit more about the angulation of the subtalar joint. But just know it is also a triplanar joint, so although it typically only has 2 motions that it goes in, it travels in all 3 planes. So about those 2 motions are going to be inversion and eversion. In terms of passive range, the subtalar joint has, again, varied numerical values according to different authors. Inversion is typically, though, reported to be about 15 to 20 degrees of passive, and then eversion is roughly 5 to 10 degrees. Regardless, though, as a general rule of thumb, 2/3 of the motion of the subtalar joint is going to be inversion, while the other 1/3 is given in eversion. Alright, so why do we have a limited range of motion in eversion? Can you think? Let's go to the picture real quick. Let's pull this up. Alright, so if we look at our foot, if we try to put it into eversion, then one of the reasons is we have a bony stop right here. So the fibula, along with the calcaneofibular ligament, is going to stop us pretty much as the fibula, as it everts, the calcaneus is going to be brought up closer to the fibula, and this ligament, it's going to become loose, but these two are going to pretty much end up touching each other. Okay, so that's one reason we have a hard bony stop from the fibula. And then medially, our deltoid ligaments do not want to overstretch. Wow, look how close it gets. Okay, so medially, our deltoid ligaments are going to resist excessive eversion and prevent excessive eversion from occurring, because they're tightly connected to each other. The final thing I want to discuss about the subtalar joint is that your orthotic professors will go into more detail about, but it's called subtalar neutral. And pretty much subtalar neutral is the position of the talus on the calcaneus in which none of these ligaments are stretched or very slack. None of the musculature surrounding the ankle joint and the subtalar joint is in excessive contraction or relaxation, pretty much when this alignment is just completely in neutral. So that's something that they'll go into more detail, but pretty much what subtalar neutral tells us is that if we are able to find the position of subtalar neutral, if we can get this joint in a neutral orientation, then we can passively dorsiflex and plantar flex, invert and evert the foot to see what our range of motion is. So subtalar neutral is a position that our foot goes throughout the gait cycle. And if a patient is able to achieve subtalar neutral, then we know that we can cast and correct a certain amount for that individual, and that being able to find a subtalar position allows us to have an optimal outcome. So if we can get that person to that position, then we know that we can be perhaps more strict or fast-paced in our management of them. So they'll go into a little bit better detail about what subtalar neutral is exactly and how to find it. You're going to be looking for 2 pretty much gaps of palpation right here. So one of the gaps is going to be in this area laterally, and then another gap, laterally, and then your other gap is going to be here medially, and you're pretty much going to move the foot in a certain way to where the gaps felt on the medial and lateral side are equal, and that's how you know that the talus is in a neutral position. So again, you'll be taught that more in detail and how to find subtalar neutral, but just have it as a term that you are familiar with at this point. The next set of joints we are going to take a look at are the mid-tarsal joints, or they can be called the transverse tarsal joints, but regardless, whatever name you use for them, they are formed by the talonavicular joint and the calcaneocuboid joint. So we're going to first take a look at the talonavicular joint. So this joint is similar to a ball and socket in, if you look at the talar head, how it's very convex, and then the more proximal portion of the navicular is a little bit more concave. So they almost have that roll and spin feature to them. Even though they don't, they act almost like a ball and socket because it gives the foot a lot of mobility along that medial longitudinal arch. We know that inversion and eversion, like we just talked about, occur at the subtalar joint, but the movement of this talonavicular joint helps to provide the range of motion within the subtalar joint. So being the talus, as it's able to move the navicular, it's able to get a better range of motion at its subtalar, at that other joint. So supporting the talonavicular joint, and mainly the head of the talus really, is going to be this spring ligament right here that takes up the gap from the susentaculum tali on the calcaneus right here to the navicular tuberosity. So when you think of the spring ligament, think that its function is actually opposite of its name. So what do I mean by that? Pretty much it says it's a spring, but consider it to not be very springy. The spring ligament has very little elasticity and actually is a thick, wide band of collagenous tissue. The spring ligament has to be very, very strong because during standing, the medial longitudinal arch right here is going to come down and lower the head of the talus and the navicular towards the ground. So if you go and you mark your navicular tuberosity, which will be very close to your talar head, and you move from a non-weight bearing position to a weight bearing or standing position, then you can see how much force has to come through here and how much the arch compresses and is lowered to the ground. Now you'll do this in a very particular way, and that will be called the navicular drop test, which your orthotic teachers will explain to you in greater detail eventually. But this is what they're talking about when they're talking about that navicular drop test, is how much the head of this talus and the navicular are being forced, are being pushed down. Now the spring ligament right here, this ligament, oh sorry, my computer just told me it was noon. So this spring ligament right here, it's pretty much meant to prevent the arch from collapsing too much. So we need a little bit of collapse for the foot to be a supple, flexible foot, but not too much to where we injure it. Now, as you can see, this does not say spring ligament. It says plantar calcaneonavicular, which is another name for it. This ligament has a few different names, but typically it is called the spring ligament. Additionally, there are two other ligaments that help to support the talonavicular joint. Right here, we're going to have the talonavicular ligament on the dorsal side of the foot, and then the bifurcate ligament, which helps to support our cuboid as well, but it's going to help our talonavicular joint also. Okay, so that's just a quick look at it. The spring ligament looks to be right here. All right, yes, there it is. So that's our spring ligament. Typically, I've seen it fan out a little bit more than what this image is showing. Okay. All right, so let's keep going.